All right, so we're going to talk about obesity and dyslipidemia. First, we're going to start with a case scenario, kind of get you guys to think about the kind of patients that we see and to think about other differential diagnosis when we are evaluating these patients. So this is a 40-year-old African-American male, chief complaint of abnormal weight gain. He's had increasing weight gain over the last 1.5 years, and I'll show you the growth charts in just a minute. He's had a total weight gain of 30 pounds over 1.5 years. Nocturia, polyuria. He's had an insatiable appetite, always wanting to eat, multiple hours of screen time. He has a history of elevated blood pressure, and he was recently diagnosed with obstructive sleep apnea. The brief diet history for him. So breakfast, he eats 2 pancakes, sausage, milk, water, juice, cereal with 2% milk, pizza for lunch, about 2 slices. He has vegetables, orange, white, and chocolate milk. Afternoon snack is animal crackers. Dinner is fried chicken, 2 pieces, mashed potatoes, mixed vegetables. And bedtime snack is dessert. And the total calories reported based on this is about 2635 calories. So, oh, okay. All right. Should we just do it like this? Maybe they're able to see this. Okay, well, we'll just do it like this, not the official PowerPoint method. So this reported calories 2635. So do you guys know like the recommended amount for like a 2 to 3-year-old? What's the ballpark? Yeah, like 1,000 calories, maybe like, 4 to 5, 5 to 6 is kind of like, 1,600 to 1,800, but yeah, more than twice the amount that they should be getting. Past medical history of just intermittent asthma, birth history, was born at 36 weeks, twin gestation, birth weight was 6 pounds, 8 ounces, and no known history of failure to thrive during pregnancy, okay? No surgeries, there is family history of obesity in the parents, but patient actually lives with his grandparents, goes to 4K. No developmental delay, and his only medication is albuterol PRN. Physical exam, so his blood pressure is a little bit elevated. Weight is at the 99th percentile, height is at the 94th percentile, and his BMI is 25.33, which is 100th percentile. He is obese on exam. He's got some acanthosis. He does not have any striae. He has a rounded facies with some temporal fullness. Otherwise, belly's a little bit protuberant, no phallic enlargement. He does have a posterior fat pad. Otherwise, behaviorally, he's appropriate for age. Okay, and this is his growth chart. And this is height, and this is BMI. Okay. All right, so what do you guys think is the most likely diagnosis given this patient's clinical scenario? No, but see, so all right, what do you guys think? It is exogenous obesity, and the reason for that, so Cushing's, you would think that this person would have increasing weight gain, but would have failure of growth, which this patient does not have. Prader-Willi, so remember, he did not have any history of failure to thrive during childhood or, as a baby. So that was one of the key things, that most of these kids, or all of them, have some degree of failure to thrive, developmental delay, and hypotonia. So like around 2 to 3, 2 I would say, which I've seen, but usually 2 is when they start gaining increasing weight, okay? And then hypothyroidism, same thing. They would gain a little bit of weight, definitely not to this degree, but they would also have growth failure, and this kid does not. So this is exogenous obesity, okay? And then what? Yes, yeah, linear growth failure. Yes, absolutely. What evaluation would you obtain for this patient? You get a BMP, A1C, lipid panel, AST, ALT, or you would add on a fasting insulin level, cortisol level, a TSH, a free T4, cortisol, A1C, or everything. Okay, I like that. Yeah, the cortisol level, you know, real life, we probably would get it to make sure if we are concerned enough on follow-up. He's got some striae now, he's got a posterior fat pad, but on the boards, it's going to be A. You want to see what the fasting glucose is, what the A1C is, cholesterol, evaluate for fatty liver, but don't get a fasting insulin level. It has no real value. Okay. All right, so his labs, so thyroid, they did get thyroid studies, they were normal. A1C is normal at 5.4%. His glucose was 90 for fasting, which is normal, and calcium as well, 10.9. And the cholesterol panel shows an LDL of 69, triglycerides of 101. So everything looks okay. What treatment options would you recommend for this patient? Everything, right? Yes. So you want to recommend increasing physical activity, discontinue sugary beverages in the diet, limit screen time, and incorporate more whole grains, fruits, and vegetables in the diet. So that's basically what our lecture is going to focus on, but we'll talk a little bit more. Okay, so based on the NHANES survey from 2000, so we are using BMI percentile curves to define obesity for children greater than 2 years of age. So the CDC says if they are between the 85th and 95th percentile, they are categorized as overweight, and obese if the BMI is greater than the 95th percentile. Okay, and extreme obesity if the BMI is greater than the 120th percentile of the 95th percentile. And you use the standard weight for length curves for children under 2 years of age, and they are considered obese if the sex-specific weight for length is greater than the 98th percentile on the WHO chart, okay? So I think we all know this, and the data keeps changing. This is from a few years back, but there is significant increase in frequency of overweight children, 12 to 30% in developed nations, 2 to 12% in the developing world. In American children and adolescents aged 2 to 19 years, 31.8% have BMI greater than the 85th percentile, and 18.5% have BMI greater than the 95th percentile. So it's increasing. And African American children are at higher risk for obesity, with 24% of those kids, and 21% Hispanic, and 14% Caucasian. Okay. So short and long-term complications of obesity are many, but some of them that we'll talk about just to kind of touch on today are obviously impaired glucose tolerance and type 2 diabetes, hypertension, dyslipidemia, PCOS, fatty liver disease, sleep apnea, orthopedic problems like SCFE, and psychosocial problems. Okay, so I think you guys, if you just think back in the last 2-3 months, we have been seeing way more type 2 diabetes being admitted to the hospital. And if you worked in our clinic, you are going to be seeing this way more. I don't know if it's the decrease in activity with COVID, but we are seeing way more type 2 diabetes. So, and we get this quite often, which is increased prevalence of pre-diabetes in obese children with a fasting blood glucose greater than 100, but less than 125. And the 2 hours post oral glucose tolerance test glucose between 140 and 200, and A1C between 5.7 and 6.5%. Okay. And obviously type 2 diabetes, more so in the African American, Native American, and Hispanic children. And the diagnostic criteria are fasting blood glucose greater than 126 on 2 separate occasions, or blood glucose greater than 200 with symptoms of, or this is a random glucose with symptoms of polys, And then 2 hours post-oral glucose tolerance test glucose greater than 200, right? And then obviously A1C greater than 6.5%. So risk assessment, when do we start screening? Obviously, if they have polyuria, polydipsia, you are going to be checking more earlier, but the recommendation is at onset of puberty or greater than 10 years of age, whichever is earlier in children and adolescents who are overweight or obese. And they also have other risk factors, including maternal history of diabetes or gestational diabetes during that child's gestation, family history of type 2 diabetes in first or second degree relative, race, ethnicity, signs of insulin resistance, or other conditions such as hypertension, dyslipidemia, PCOS. And if the initial tests are normal, you can repeat testing 3 years later or more frequently. If the BMI keeps increasing, these kids will probably get screened here. Okay. So hypertension, so these kids are all being seen in nephrology, but the rate of hypertension is 10% in children with BMI greater than the 97th percentile. And these are the kids with primary hypertension. And I think you guys have all these, have looked at the charts where you figure out if this blood pressure is, what percentile it is based on the age, gender, and height. That's what you use. And blood pressure greater than the 95th percentile is categorized as hypertension, but I wouldn't go by just one reading. I don't know, have you guys done nephrology? I think they do like multiple readings, right? So we frequently see elevated blood pressure in our clinic, but I usually have them check it at school nurse, or do ambulatory measurements and then come back. The pathophysiology, so there's multiple factors, but basically sympathetic nervous system hyperactivity, the insulin resistance does not help. Maybe there's some abnormalities in the vascular structure and function, and overall inflammation from obesity, but I don't think there's like a one pathway that's causing primary hypertension. This is not like renal artery stenosis or anything like that. Okay, and then PCOS, again, increasing prevalence. Adolescent females frequently present with irregular menses, acne, hirsutism, obesity, and insulin resistance. So there is some controversy. You can't diagnose PCOS in the first year to 2 years after they start cycles. So you want to wait at least 2 years, but so you want to be a little bit careful about diagnosing them and labeling them as such. But if they have all these features, they are definitely on the pathway to PCOS. So these are the kids that have frequently elevated androgens. So I frequently check free testosterone, DHEAS, androstenedione, and also make sure this is not non-classical CAH with checking a 17-hydroxyprogesterone level. And they can frequently have a low sex hormone binding globulin and an elevated LH to FSH ratio. Yes, so because there are other women who are not as obese and still have some of these features. So, but obesity, the presence of all this adipose tissue could increase secretion of insulin, also make the ovaries produce more of these androgens, and it kind of, yeah, yeah. So yeah, increased insulin resistance, which pushes to increasing fat deposition. There's some low-grade inflammation with these TNF alpha and IL-6, which increases insulin resistance. And then they have dysfunctional ovaries, which leads to increased androgen biosynthesis and have signs and symptoms of hypertension. So I just touched briefly on treatment for PCOS. So we frequently use estrogen progestin combination oral contraceptive because they decrease the hyperandrogenemia and regulate the menstrual cycles. Because they help with gonadotropin suppression, they increase the androgens binding and also bind the androgen receptor. So they basically decrease the symptoms of acne and hirsutism. And if that by in itself is not enough, You can add spironolactone, which is basically antagonizes the androgen receptor, but you can't really use spironolactone by in itself because if the patient were to get pregnant, it can feminize the male fetus. So you'll frequently use them together. So I have never used it by itself. I would do both together if they need, more help. All right, and if they are overweight and obese, really lifestyle modifications, and also have evidence of impaired glucose tolerance, that's when you would be adding metformin. I don't frequently use metformin. The only times I feel like I've used metformin are if they're against using OCPs for whatever reason and they only want to try metformin. It does work to some degree, but some of these kids still need OCPs to make their menstrual cycles more regular. All right. The fatty liver disease, fatty infiltration of the liver can be seen in almost 50 to 75% of obese children. And I think we see this frequently when we're getting CMPs. 10 to 25% of obese children have elevated LFTs. This can progress to liver fibrosis and cirrhosis and may end up getting liver transplant. And then duration of obesity is actually what correlates with the severity of fatty liver and not necessarily the degree of obesity. Okay. And they can also have cholelithiasis and gallbladder disease. Obstructive sleep apnea can be pretty persistent, and if not treated, long-standing OSA can lead to cor pulmonale. Orthopedic disorders, Blount's disease, this is where the inner part of the tibia is not developing properly, so they have angulation of the tibia and leading to progressive bowing, commonly seen in African-American males. I don't see as much of it, but you guys have seen it probably in clinic? Yes. Okay. SCFE, slip capital femoral epiphysis, where the epiphysis of the proximal femur slips off the corresponding metaphysis. They usually present with limb and hip pain or referred pain to the knee, but could be a complication of obesity. And psychosocial impact, when we see this all day in clinic, they are bullied, they have poor body image, low self-esteem, and frequently have symptoms of depression, suicidal ideation. So all right. Pathogenesis of obesity. So what exactly is causing these increased rates of obesity and why are we seeing so much of it? There's multiple factors, is what I have read and seen. Genetics obviously plays a role. Environmental factors, so if you already are genetically predisposed and you have the right environmental factors, you are more prone to becoming obese. And the modern Western diet has high fat, calorie dense foods, large portion sizes, and overall the physical activity levels have decreased, right? We have more increased sedentary activities and tons of television, computer, and video games. So this all comes down to calories eaten, calories burned. If there's excess, you are going to gain weight. And there's this thrifty gene hypothesis where, so there's some genetic traits that predispose us to obesity. So evolutionarily, we are the chance of survival is higher if we are storing more as fat. So maybe that's that's why our bodies are kind of prone to gain more weight, and that's why there's increasing rates. I don't know. So thin and normal weight individuals have a tightly regulated feedback in when they're full, when they need to stop eating. That helps to regulate their appetite and metabolic rate and maintain a normal weight in general. But the obese individuals are maybe not as tightly regulated, so miss these cues and lead to increase in weight gain. Every 3,500 calorie consumed in excess of what they need, you can have 1 pound of adipose tissue gained. And if there's no increase in metabolic rate, 50 kcals per day for 10 years can lead to 50-pound weight gain. So that's not a lot, just 50 extra calories. And then extra 200 calories per day, which is like what, like a small Snickers bar or something, can lead to 100-pound weight gain in 5 years. So it's not as easy. Oh, sorry, it's pretty easy to gain weight, is what I'm trying to say. All right, so a differential diagnosis, and we kind of touched on it, but so if they are gaining weight and there's an increase in BMI with poor linear growth velocity, that's when you think about endocrine issues, okay? When they are gaining weight and their height velocity is appropriate, it's very unlikely to be endocrine related, but some of those things are hypothyroidism, growth hormone deficiency, glucocorticoid excess, and then syndromes. They, Prader-Willi syndrome, like we talked about, they present with hypotonia, failure to thrive, and then severe obesity as time progresses from 2 years of age. Bardet-Biedl syndrome, obesity, some eye issues. They also have developmental delay. And then Albright's hereditary osteodystrophy, they have PTH resistance, have calcium issues, but also have obesity, shortened metacarpals. So I have not seen that yet. And then hypothalamic injury. Frequently after brain tumor, we do see this, the hypothalamic obesity. And then single gene mutations are less than 10% of cases of obesity. We have not been as proactive in doing genetic testing for all of our obese patients, only because of insurance reasons. And a lot of times what is treatment really is to do lifestyle modifications and increasing physical activity, unless they have like leptin problem. But there are some institutions that are doing it, and I feel like in the right scenario, you may want to think about it. So these are the kids that have very young onset obesity, and they have they have food-seeking behaviors, constant preoccupation with food. There's family history of obesity, but it's like the really young onset that you want to think about monogenic causes. So MC4R mutation, these kids have obesity as well. And then POMC deficiency, they love this on the boards. So they present this kid with fair skin, red hair, adrenal insufficiency, and they also have eczema. I feel like I've seen that before. So prevention, you want to implement healthy eating habits. I think I'll kind of know this, but just take away all the sugar sweetened beverages, sports drinks, fruit drinks, fast foods. Just avoid juice. Unless they are using it for constipation, really, these kids, no juice, okay? And they say at least 20 minutes, but preferably 60 minutes of moderate to intense, severe physical activity, at least 5 days per week. And then you want to limit screen time. And you can't just do all these things with just the patient. We frequently have this happen in clinic when we were doing our healthy lifestyle clinic. The mom's always saying, I'm always telling her to not get into my sodas. I'm frequently telling her, you know, don't get into my candy. It does not work. You have to have the entire family be involved, and everybody has to do it, because it is impossible for your 9-year-old patient to not want to eat chocolates and candy or whatever, soda, if it's there in the house. So, and that's the hardest part, is having the entire family get on the picture. And I do wonder, you know, we probably shouldn't have healthy lifestyle clinic for the patient, but maybe for the entire family. And that's maybe part of the reason why it failed. I don't know. So treatment of obesity, I would say, is a little bit controversial because I talk about pharmacotherapy, but so healthy eating habits, increasing physical activity. I have not done orlistat before. I do see it occasionally. There's some kids that were started in outlying clinics, but you can, if the BMI is greater than 30 or other associated symptoms like hypertension and type 2 diabetes, even with the lower BMI, and they're over 16 years of age, you can try orlistat. because it reduces fat absorption by 30%. But I've read that most of these kids don't end up continuing on it because of GI distress. So, but it's there. And last is bariatric surgery, right? So these kids have finished puberty, they have done everything. They've done healthy eating habits, they've done physical activity, and they have other comorbidities like, obstructive sleep apnea. They have to take insulin. Okay, bariatric surgery is there. I don't know if anybody's really doing it here, but if the family wants to think about it, we can offer, okay? And then they need an experienced bariatric surgeon. They need to go through a complete psychological evaluation, and they need to be able to continue the lifestyle modification even after surgery, okay? All right, okay. Yes. The juice and whatever, the milk and chocolate milk and this and we check the A1C. Yeah. All right, so you guys get a Jolly Rancher if you guys get this question right, and it's 70 calories, by the way. I did not do the Snickers bar that I was planning to because it was 200 calories, and we are doing a lecture on obesity. So, 15-year-old boy, routine well-child visit with his primary care physician. Physician notes a 20-pound weight gain in the last year. Patient has no symptoms of polyuria, but he reports always being thirsty. He is here for evaluation. On further questions, he learned that his mother and maternal grandfather have type 2 diabetes, so high risk, right? On physical examination, he has a dark rash on his neck and axilla, and his BMI is 33. A random blood glucose measurement in your office is 199. You request an OGTT, which documents a 2-hour glucose value of 228. You decide to start metformin therapy. So this kid has type 2 diabetes, right? Because he meets the criteria greater than 200 at the 2-hour mark on the OGTT test. Before initiating therapy, which are the following tests should be performed first? So lactic acidosis is a known risk complication with metformin, and if they already have renal disease to begin with, you increase risk of lactic acidosis. So all these kids that come in and with type 2 diabetes, their blood sugar is 500, their creatinine is like 1.2. We always say, just hold off on the metformin for now. We can start outpatient. So that's what we're talking about. Okay. All right. Okay, and let's see. Okay, so, sorry, these questions are all from like the PEDS Endo Boards prep questions, okay? Parents of a 3-year-old girl are concerned about her obesity. According to her growth history, she had a normal birth weight, but during infancy, she exceeded the 95th percentile for height by 4 months of age, with continued rapid increase in both height and weight. Her weight gain has been more dramatic than her height gain. Her medical history is notable for 4 seizures by age 9 months. The 4th seizure was associated with hypoglycemia. Her parents report that another endo-diagnosed adrenal insufficiency at that time, although you don't have those records. Hydrocortisone therapy was initiated, after which she did not have any further hypoglycemia or seizures, and she's on a physiologic replacement dose, okay? Her parents report that she's otherwise in good health. She has not had excessive thirst. You note that both parents are obese, so her ACTH is undetectable, and they also checked an IGF-1. Why did they check the IGF-1? So you're trying to rule out what? Exactly. Good job. You get a Jolly Rancher too. So it's growth hormone excess. That's what they're doing. The ACTH, I don't know if I agree on checking that, because they got that while the kid was on hydrocortisone. So that adrenal gland, everything's suppressed. That feedback regulation is gone. So I don't agree with that. But what do you guys think is the most likely etiology of her weight gain? Talked about it. Obese, adrenal insufficiency. No. Yeah, monogenic, yes. This is POMC deficiency, exactly. Single genetic cause of both obesity and adrenal insufficiency. Very, very rare, but you know, these are the board questions. They will also say, oh, she has fair hair, you know, fair skin, red hair, but they didn't say hair. Okay. So it's not hypopit. Yeah, and also, you know, they would give you a setup like she had, you know, central line defect or something like that, and then wouldn't have that much obesity, right? So unless she had like a brain tumor or something, and now you have hypothalamic obesity. So all right, so just briefly, pediatric metabolic syndrome, we always see this. So what are they exactly talking about? This is central obesity with a waist circumference greater than 90th percentile for age, gender, and ethnicity, plus 2 of the following. So these kids have raised triglycerides greater than 150 milligram per deciliter. They have reduced HDL less than 40 in boys and then less than 50 in girls greater than 16 years of age. They have elevated blood pressure and elevated fasting plasma glucose. So that's what they're talking about with metabolic syndrome, basically. Okay. Treatment, lifestyle interventions in a multidisciplinary setting, again, involve the whole family, maybe some CBT. Metformin, I've seen a few patients being started. It's kind of hit or miss for this. I don't start it unless they actually have diabetes, but I have seen even for metabolic syndrome, metformin to be started, even with the, you know, fasting glucose between the 100 to 125, with the low, in conjunction with the low calorie diet. All right. The dyslipidemias, I think we see this frequently, right? Especially in our kids with obesity. So they can have abnormal serum levels of LDL, HDL, and or triglycerides. You have gender and age specific standards for lipid and lipoprotein concentration in children and adolescents. So you could have hereditary, secondary, or associated with environmental factors like diet and physical or obesity. All right, so this basically tells you for triglycerides or LDL, like you're looking at the 95th percentile for these age groups. So like around 130, 140 is when you're starting to get concerned. HDL, 50th percentile is 55, 46 for 15 to 19-year-olds. And then triglycerides, the 15 to 19-year-olds, like around the 143 or 111. And girls, it's around 120, okay? So this familial hypercholesterolemia, this is the kid who's like 12 years of age, skinny, has really no other risk factors, no obesity, no hypertension, nothing, but has an LDL of like 250. So that's your familial hypercholesterolemia. This is an autosomal dominant disorder, which is a mutation of the gene encoding the LDL receptor. And the heterozygous form is the most commonly inherited disorder. It's like 1 in 500. So they have elevated LDL and positive family history of hypercholesterolemia. And there's history of premature cardiovascular disease, which is less than 55 years for male and less than 65 for female relatives, okay? And they're usually asymptomatic. So the homozygous mutations are the ones, the LDLs are like in, you know, hundreds, very, very high, and they could have myocardial ischemia in the first decade of life. So, these are more severe. And then autosomal recessive hypercholesterolemia, they also present with increased LDL levels with only slightly elevated LDL levels in parents, and they behave more like the heterozygous patients. Inherited hypertriglyceridemias, have you guys seen this? Okay, so the serum really looks like milky yellow, kind of cream colored when you get the triglycerides in these patients, because they're frequently like in the thousands or 50, you know, 1100, that kind of range. So there's a problem with the lipoprotein lipase hormone, which is involved in the metabolism and causes the hydrolysis of the triglyceride core of the chylomicrons and VLDL. So they have very elevated triglycerides and have a milky serum. They can have like eruptive cutaneous xanthomata. They can have hepatomegaly, eye findings, and the one that we worry about a lot and maybe have seen is recurrent pancreatitis. Okay, so this is the 500 or above is when we start worrying about pancreatitis. And the secondary causes of dyslipidemia are first is obviously obesity. They could also think about hypothyroidism. I do frequently check TSH and a free T4 if I do see kids that are coming in for the first time with elevated LDL or triglycerides, just to make sure. Nephrotic syndrome, these have very elevated cholesterol levels as well. Hepatic disorders, solid organ transplant, HIV, cancer, poorly controlled diabetes, frequently have hypertriglyceridemia. A lot of times with the type 2 diabetics that are coming in with an A1C of like 11%, we get the lipid panel and the triglycerides are like 600, 700. Don't treat yet. Get the blood sugars under better control, and a lot of times you are going to see that get better, okay? Medications such as antiretroviral regimens, anticonvulsants, retinoids, immunosuppressants, and psychotropic medications are all known to cause dyslipidemia. All right, so American Academy of Pediatrics recommends screening overweight, so BMI greater than 85th percentile children with a fasting lipid profile starting at 2 years of age, and then retest in 3 to 5 years if normal. And then universal screening around 9 to 11 years of age, and again between 17 and 18 years of age. So the treatment, first you really want to try lifestyle modifications for at least 6 months, which is less than 10% of total calories from saturated fat, less than 30% of calories from total fat, less than 300 milligrams of cholesterol daily. And then statin therapy. So you've tried lifestyle modifications for 6 months, the LDL is still elevated. So 10 years of age and LDL greater than 190, you want to think about that. LDL greater than 160 and family history of early cardiovascular disease plus risk factors of early cardiovascular disease. So these are the kids who are obese, have hypertension, have other high risk factors, or history of smoking or any of those, okay? And then LDL greater than 130 plus high risk condition like diabetes. So these are frequently our type 1 diabetes who have like LDL of 140, 150. We tried 6 months of diet, nothing's changing. So these kids are getting started on statin. And you want to check and make sure the LFTs are normal baseline before starting. All right, so triglycerides are a little bit more harder to treat. So obviously, first you want to try lifestyle modifications. Omega-3 fatty acids, fish oil. This is like the triple strength fish oil, TID. So it's like high doses, and compliance is not as good with these in the kids. But it decreases hepatic secretion of triglycerides containing lipoproteins. And then there's increased clearance of triglycerides. You can also try niacin. I've not tried it before, but I think I've seen it more in adults being tried. And then if they also have elevated LDL and triglycerides, you could try statin. And last but not least, some of these kids who have really high triglycerides, you could try fenofibrate, okay? Because they increase lipolysis and reduce the apoprotein C3 because it actually acts as an inhibitor of the LPL activity. So you have more LPL activity. All right, so I think these are our last of the questions. So in clinic, you see a 15-year-old boy for the first time. He's taking atorvastatin for elevated cholesterol. At age 12, he was noted to have an LDL cholesterol concentration of 220, so greater than 190, right? Which was consistent with his family history of hypercholesterolemia and early heart disease. His high LDL level prompted the initiation of statin, 10 milligrams daily. At today's visit, his LDL is 222. His parents are supervising his medication over the last 3 years, and he has nose xanthomatous, and physical exam is standard stage 4. What do you guys think? Do you think he is unresponsive, or you want to add something else? For this question, you guys got to know what the starting dose of statin would be. So 10 milligrams is the smallest dose. What do you guys think? Yes. So I think I wouldn't have known what the starting dose was, because I think some of them are like 5, some of them are 10. But this kid has been on it for a few years. He's apparently taking it. His level's still 222. You definitely want to increase. Okay. You can go up to 20. So. All right. And so statins decrease LDL by 25%, and then other agents, there's not as significant of a decrease. So if you are thinking about increasing, you are going up to 20 milligrams. All right, so 14-year-old boy with type 1 diabetes has a long-standing history of A1C levels greater than 10% over the past 4 years. Fasting lipid panel reveals an LDL concentration of 168 and a triglyceride concentration of 109. In his medical record, you see that when diabetes was diagnosed 6 years ago, his LDL was 108 and triglycerides were 100. Last year, the family was instructed to pursue a diet low in saturated fat and cholesterol. His paternal grandfather died young of heart disease. What do you guys think? Yes, yes. This is a high-risk patient, right? Type 1 diabetes, poor glycemic control. Yes, we could wait for the glycemic control to get better, but how long are we going to wait? And the LDL is over 130. So your goal in this kid is to get that LDL less than 130. Okay, so you are going to start statin on this kid. So these are just some of the references. A lot of the stuff, I kind of have it from my textbooks and prior lectures, and these are what I reference quite frequently. So those are there for you guys. Questions? Yeah. I think you definitely want to know the definitions, and you want to know the diagnostic criteria for diabetes and impaired fasting glucose. You do want to know about Prader-Willi, the POMC mutation, the adrenal insufficiency. They love that correlation for boards. And then obviously all the syndrome, Prader-Willi, they love Prader-Willi. You know, they're going to ask questions on that. And then Beckwith-Wiedemann. Okay? All right. Thank you, guys.
Thanks, Dr. Nirala.
Thank you. Bye, Rachel. All right. So,
Ooh, bring it back. Where else would you get closer up?